This is a video in clinical medicine from the New England Journal of Medicine.
Supplemental oxygen is commonly used in modern medicine and is fundamental to the treatment of hypoxemia. This video focuses on the administration of supplemental oxygen in adult patients in an acute care setting through a nasal cannula, simple face mask, face stent, Venturi mask, non-rebreather face mask, or high-flow nasal cannula. Each technique may vary depending on institutional guidelines, the available equipment, and the manufacturer's instructions. The most common indication for the administration of supplemental oxygen is acute or chronic hypoxemia, which can be caused by pulmonary infection, chronic obstructive pulmonary disease, congestive heart failure, pulmonary embolism, or shock with acute lung injury, among other causes. Oxygen therapy can also be beneficial in patients with burn injuries, carbon monoxide or cyanide poisoning, gas embolism, or other conditions. There are no absolute contraindications to the administration of supplemental oxygen. Oxygen is transported in the blood to most tissues. In the blood, oxygen binds to hemoglobin, although a small fraction is dissolved in the plasma. The oxygen-hemoglobin dissociation curve shows the relationship between the partial pressure of arterial oxygen, or PaO2, and hemoglobin oxygen saturation. When the PaO2 is greater than approximately 60 millimeters of mercury, the curve is relatively flat, and the oxygen saturation does not change substantially. However, as the PaO2 falls below 60 millimeters of mercury, the slope of the curve becomes steeper, reflecting a sharp decrease in oxygen saturation with insufficient oxygen delivery to the tissues. Administration of supplemental oxygen becomes critically important when approaching this threshold. Factors that shift the oxygen-hemoglobin dissociation curve to the left include a decrease in temperature, a decrease in 2,3-diphosphoglycerate, or 2,3-DPG, and alkalosis. Factors that shift the oxygen-hemoglobin dissociation curve to the right include an increase in temperature, an increase in 2,3-DPG, and acidosis. Pulse oximetry is particularly useful to monitor the hemoglobin oxygen saturation and is indicated in all clinical settings in which hypoxemia may occur. In many hospitals, a medical gas pipeline is the primary source of oxygen. When a pipeline is not available, E-cylinders are commonly used. A full E-cylinder with a pressure of 2,000 pounds per square inch or 14,000 kilopascals contains approximately 660 liters of oxygen. Thus, at a set flow rate of 5 liters per minute, an E-cylinder would be able to deliver oxygen for 2 hours. H-cylinders are also commonly used in hospitals that do not have a central oxygen supply. When full, H-cylinders contain approximately 7,000 liters, or 10 times more oxygen than an E-cylinder. In the hospital setting, the flow rate is typically measured with the use of a variable orifice flow meter. The flow meter is attached to the oxygen source, and the measurement is obtained at the center of the floating ball. The flow can be adjusted with a fluted knob. Flow meters have a tube that is tapered, with the smallest diameter at the bottom, to create a variable annular space between the ball and the inner wall of the tube. Flow meters are constructed specifically for a given type of gas, since the flow depends on the viscosity and density of the gas. The meters must be oriented vertically to function correctly, since the ball is suspended in the gas stream. E-cylinders are commonly equipped with click-style flow meters, which are easy to use, sturdy, and capable of operating at any angle because they are unaffected by gravity. A nasal cannula is a flexible tube with 2 soft prongs that are inserted into the patient's nostrils. It is lightweight and can be used at the hospital, at the patient's home, or elsewhere. The tubing is usually looped behind the patient's ears and then brought in front of the neck. A sliding toggle is adjusted to secure it in place. The main advantage of the nasal cannula is patient comfort, including the ability to easily speak, drink, and eat with the cannula in place. When oxygen is delivered through a nasal cannula, inspired ambient air mixes with the oxygen in varying proportions. In general, the fraction of oxygen that is inspired above the normal atmospheric level increases by approximately 4% for every additional liter per minute of oxygen administered. However, an increase in minute ventilation, that is, the volume of gas inhaled or exhaled in 1 minute, or mouth breathing, can dilute the oxygen and result in a lower fraction of inspired oxygen or FiO2. Oxygen can be administered through a nasal cannula at a flow rate of up to 6 liters per minute. However, lower oxygen flow rates are less likely to cause nasal dryness and discomfort. Like a nasal cannula, a simple face mask can be used to administer supplemental oxygen in a patient who is breathing spontaneously. The simple face mask does not have a reservoir. There are holes on both sides of the mask that allow the flow of ambient air during inspiration and the release of exhaled gas during expiration. The FiO2 is determined by the oxygen flow rate, the fit of the mask, and the patient's minute ventilation. In general, the administration of oxygen at a flow rate of 5 liters per minute generates an FiO2 of 0.35 to 0.6. Condensation of water vapor in the mask provides a visual cue of expiration and is rapidly cleared when appropriate fresh gas flow is provided. Disconnection of the oxygen tubing from the source or a low oxygen flow rate can cause the patient to receive insufficient oxygen and rebreathe exhaled carbon dioxide. These problems should be addressed immediately. Some patients may find that the face mask feels confining. A face stent provides a controlled concentration of humidified oxygen through an open mask that fits under the patient's chin, covering the nose and mouth without creating a seal around the nose. With a flow rate of 5 to 15 liters per minute, it can provide an inspired oxygen concentration of up to 50%. Placement of a face stent is ideal for patients who cannot wear a tight-fitting mask. However, its loose-fitting design and flow limitation further contribute to the inability to control the FiO2 precisely. A non-rebreather face mask is a face mask that has been modified to include an oxygen reservoir bag. A unidirectional valve allows flow of oxygen from the reservoir during inspiration, but closes the reservoir during expiration, allowing the reservoir to fill with 100% oxygen from the fresh gas source. Non-rebreather face masks may be equipped with 1 or 2 side vent valves that close during inspiration to prevent entrainment of ambient air and open during expiration to minimize rebreathing of exhaled gas and reduce the risk of hypercarbia. Typically, non-rebreather masks are equipped with a valve on only one vent, allowing the flow of ambient air through the valveless vent. When oxygen is administered through a non-rebreather face mask, the flow should be set at 10 to 15 liters per minute, and the patient should be monitored closely to ensure adequate fresh gas flow from the reservoir, particularly if the mask is fitted with 2 unidirectional side valves. The reservoir bag should deflate only partially during inspiration. Complete deflation of the bag indicates insufficient gas flow. Insufficient gas flow is particularly dangerous if the non-rebreather mask is equipped with 2 side vent valves, because the valves may prevent the patient from inspiring room air, which could lead to suffocation. This situation requires immediate attention. A non-rebreather face mask can deliver an FiO2 to the patient between 0.6 and 0.9. A Venturi mask takes advantage of the principle of jet mixing to entrain and blend ambient air with oxygen. As oxygen passes through a small orifice into a larger chamber, its velocity increases. This causes the ambient air to be entrained with the oxygen. Air entrainment can be controlled through manipulation of the orifice or the size of the air entrainment port, resulting in a gas mixture with a predetermined FiO2. The color-coded entrainment devices at the base of the Venturi masks have orifices of different diameters that can deliver an FiO2 between 0.24 and 0.5, provided the required oxygen flow rate is set as specified by each manufacturer. After air entrainment, the overall gas flow rate can be as high as 60 to 70 liters per minute. The color coding in a Venturi mask can vary across manufacturers, so extra attention may be needed to set the correct oxygen flow for each of the air entrainment devices. The delivery of supplemental oxygen through a nasal cannula or face mask can be inefficient because of flow limitations, particularly in patients with a high inspiratory flow or high minute ventilation. A high-flow nasal cannula can deliver oxygen at a flow rate of more than 40 liters per minute. The oxygen is humidified and heated to a temperature of 37 degrees Celsius to prevent discomfort and mucosal injury. Before a high-flow nasal cannula is placed on the patient, it should be set up according to the manufacturer's instructions. There is a breathing circuit that consists of an air-oxygen blender, which is used to adjust the oxygen concentration, and a flow meter, which is used to adjust the flow. There is also a heated humidifier that continuously monitors the airway temperature and regulates the heating element. A sealed heated wire within the circuit may be used to minimize condensation within the tubing. Sterile water is supplied in a pre-filled disposable reservoir. Water flows from the reservoir into the humidification cartridge, where it is vaporized. To administer oxygen through a high-flow nasal cannula, connect the oxygen tubing to the hospital oxygen pipeline and connect the air tubing to the hospital air pipeline. Set the desired oxygen concentration on the air oxygen blender and adjust the flow rate on the flow meter. Connect the high-flow nasal cannula to the breathing circuit and make sure that there is adequate gas flow through the nasal prongs and allow the gas to become warm and humidified before fitting the cannula to the patient. Position the nasal prongs in the nostrils and secure the cannula. The prongs should not completely seal the nares. If they do, a smaller cannula should be used. High-flow nasal cannulas generate a modest positive end expiratory pressure. Their use may result in a decrease in atelectasis and an increased functional residual capacity. The efficacy of these devices may be enhanced by a washout effect in which carbon dioxide is washed out from the anatomical dead space and replaced with oxygen-rich gas, thus improving breathing efficiency. In addition, the administration of supplemental oxygen through a high-flow nasal cannula can reduce the need for endotracheal intubation and mechanical ventilation. The use of high-flow nasal cannulas was initially avoided in patients with COVID-19 because they were thought to be associated with an increased risk of aerosolization and airborne transmission of the pathogen. However, emerging data suggests that this device may be used in patients with less severe forms of COVID-19 pneumonia without posing major risks to healthcare providers as long as appropriate personal protective equipment is used and precautions against airborne transmission are taken. A surgical mask can be placed on the patient to reduce droplet deposition and the risk of particulate contamination. Oxygen supports and accelerates combustion and causes materials to ignite and burn more rapidly. To minimize the risk of fire during the administration of supplemental oxygen, it is important to avoid contact with sources of ignition and flammable materials. Increased oxygen tension can accelerate the production of reactive oxygen species such as superoxide, hydroxyl radical, and hydrogen peroxide. Reactive oxygen species can impair the function of intracellular macromolecules and proteins, leading to cellular injury, tissue damage, and the formation of hyaline membranes in the alveoli. A high concentration of oxygen displaces nitrogen in the alveoli, and the oxygen in the alveoli may be absorbed, reducing the alveolar volume. Hyperoxia can result in absorption atelectasis, which can lead to increased physiologic shunting and hypoxemia. In some patients with chronic obstructive pulmonary disease, oxygen therapy may cause carbon dioxide retention. In such patients, if adequate oxygenation cannot be maintained without life-threatening hypercarbia, mechanical ventilation may be required. Supplemental oxygen is an important therapy for a broad range of clinical conditions. Oxygen can be administered through low-flow and high-flow devices that deliver a range of gas mixtures, with or without temperature and humidity control. It is important for clinicians to understand the functions and properties of the various devices used for oxygen delivery to ensure appropriate treatment and to avoid complications.